My name is David Quinn. I'm from Albany, New York. I'm an orthopedic surgeon. I happen to be an early adopter of the modality and have found over time roughly 5% of the patients I see in the half time that I'm in the office week to week benefit from this additional imaging. Here's just a very short slide indicating the scale of our practice. But the important number there is about half of the patient visits per year include plain X-ray studies. And of the plain X-ray studies, in my share of those plain X-ray studies, about 5% of them are supplemented with digital tomosynthesis. Fundamentally, as orthopedic surgeons, we're trying to answer some very simple questions, especially with respect to fracture care. But before we've even decided that a fracture is the problem, we ask this, whether we're aware of it or not, this very simple series of questions. Is there a problem? Does the patient need an operation, or is it indicated? Has it been done properly? Is the problem resolved? And I found that digital tomosynthesis helps answer these questions in a substantial percentage of cases with minimal risk and minimal expense. So with respect to fracture care, digital tomosynthesis helps me answer the question, is there a fracture? Is it displaced? Is it intraarticular? How displaced is it, if intraarticular? With either closed or open reduction, has the joint surface been restored, and has the fracture gone on to heal? I have 3 upper extremity cases that each show different aspects of the natural history of fractures before, during, and after, or past, present, future, maybe we would call it. But this first case asks the question, is there a clavicle fracture? This was an adolescent female, maybe 16, who'd fallen off a horse and had shoulder girdle pain localized largely to her medial clavicle. She was active in sports. She wanted to get back on the horse. She presented to an ER. She presented to another orthopedic surgeon, and she had some swelling and tenderness over her medial clavicle, but her plain radiographs, if you can at least take my word for it, in a couple of instances, were normal. But because she was always at risk of falling off the horse again, we didn't want to send her back before we knew if there was a fracture and if it had sufficient time it had elapsed for it to have healed. So this is the original study, and then we'll take a moment and look at the digital tomosynthesis series. And then in the next slide, we take a screen grab of one of the series of the study, similar to taking a single cell out of a movie or out of a cartoon movie. And there we see over the very inferior medial aspect of the clavicle is a non-displaced fracture, which was precisely where she'd been tender. So knowing this, we were able to A, reassure the patient and her family that this was a problem, and B, put together a timeline for her return to full activity. This next case involved a 20-ish year old patient who had fallen on the outstretched extremity and sustained this intraarticular distal radius fracture at the junction of the scaphoid fossa and the lunate fossa that was arguably stepped off, given this patient's age and activity, to a sufficient degree to indicate restoration more anatomically of the joint surface. And so we get a sense of that on the plain film, but by obtaining a digital tomosynthesis study, which we'll look at right now, we could come to a conclusion. Looking at the screen grab from the study on the left that best showed the step off of about 2.5 to 3 millimeters, we elected to go ahead and fix this and restore the more normal anatomy, start them moving, etc. So it gave us the information that I suspected was there, but couldn't say with sufficient certainty was there to go ahead and recommend surgical treatment. And then the last case we have was this is to determine whether or not the scaphoid fracture had healed. This young man had fallen on his outstretched extremity, sustained a completely non-displaced scaphoid fracture, been treated non-operatively, and in follow-up, some 6 or 7 weeks later, really wanted to get back to his contact sport, but had a trace amount of tenderness in the snuff box. We see on the plain film that it looks like his fracture is healed, but there's a question of the ulnar half of it, or perhaps more, at least enough so that I ordered a digital tomosynthesis study to have a closer look at the healing pattern. So the next movie we'll see is a series of images that demonstrate that study. So again, taking out the most informative slice of that study, we can see quite clearly still a moderate portion of the ulnar side of that fracture is not completely healed, and put together with his tenderness allowed me to come to the conclusion to keep him out of his sport for a further time period. So those are the 3 illustrative cases that I thought might show the various ways that one can leverage this technology, this modality in my daily practice.